Hello class. Today we'll be looking at an analysis for the cost-effectiveness of Evolocumab therapy for reducing cardiovascular events in patients with atherosclerotic cardiovascular disease. The first step of this article analysis is looking at the title. The title of the study is Cost-Effectiveness of Evolocumab Therapy for Reducing Cardiovascular Events in Patients with Atherosclerotic Cardiovascular Disease. From reading this title, we can clearly see that this is a cost-effectiveness analysis. Although the title could have included that we were comparing the Evolocumab with standard therapy for the disease, I would argue that being such a common disease state with only one standard of therapy, it was not necessary to include. Furthermore, the title is not biased toward or against the Evolocumab therapy, which is a positive sign. In the case of the objective, it was clearly stated in the beginning of the article as to evaluate the cost-effectiveness of Evolocumab therapy in patients with atherosclerotic cardiovascular disease when added to standard therapy. It states the two options it will be comparing clearly, as well as which pharmacoeconomic analysis they will go about using. This is at the beginning of the article, and it clearly answers a question. The next step of this analysis is seeing if the alternatives that it looked at were appropriate. Looking at atherosclerotic cardiovascular disease, there is really only one standard of care, statins, which are recognized worldwide. Therefore, yes, this was an appropriate alternative to look at. The author also looked at ezetimibe, which is an add-on therapy for this disease state. There are no other noteworthy therapies. Now that we have named the alternatives for the Evolocumab therapy as statins and ezetimibe, we need to see if the alternatives were described. Was a comprehensive description of the competing alternatives given? In the case of this analysis, yes it was. The prices of intensive therapy were stated as generics of simvastatin and atorvastatin from the Red Book at $68. Also, the add-on therapy of ezetimibe was named as $2,780.
Next, we assess the perspective of the study being addressed. The article does clearly state that the perspective of the study is taken from the U.S. societal perspective. Additionally, the U.S. payer perspective was also used for specific scenario analyses. Perspective is an economic term that describes whose costs are relevant based on the type of study. Traditionally, using the societal perspective is the most appropriate and comprehensive, although it is not the most commonly seen because it is difficult and time-consuming to estimate all of the cost components. In terms of this study, it is a positive sign that the U.S. societal perspective was used in the analysis. The type of study was easily identifiable for readers as it was included in the title of the article. Our article addressed the long-term cost-effectiveness of Evolocumab therapy for reducing cardiovascular events in patients with atherosclerotic cardiovascular disease, or ASCVD. QALYs, which stands for Quality Adjusted Life Years, were used as the main outcome measure, which is a marker of cost-effectiveness studies. Additionally, other outcomes such as ICER, which stands for Incremental Cost-Effectiveness Ratio, and Net Value-Based Prices were also used. Next, we assess whether the important and relevant costs were included in the study. In order to do this, we assessed the inclusion of direct and indirect medical costs. Direct medical costs associated with cardiovascular events were obtained through the U.S. claims data. Indirect cost estimates were obtained from the 2017 American Heart Association, American Stroke Association reports on CVD burden by applying reported ratios on direct and indirect costs. Non-cardiovascular death events were assumed to incur no additional costs. The cost of treatment with Evolocumab was based on the wholesale acquisition cost of $14,523. So this did not include any discounts or reimbursements. The average Red Book prices and market share of generic simvastatin and atorvastatin were used for standard therapy at $68. The author of the article used various relevant outcomes to measure the cost-effectiveness of Evolocumab. He included study outcomes such as cardiovascular events, including myocardial infarction, ischemic stroke, and cardiovascular death. They also used Quality Adjusted Life Years, or QALYs, Incremental Cost-Effectiveness Ratio, or ICER, and Net Value-Based Prices. So our group concluded that yes, the most important and relevant outcomes were measured.
adjustment and discounting were appropriate and conducted in this cost-effectiveness analysis. Direct medical costs were adjusted for inflation. Direct medical costs associated with cardiovascular events were obtained through U.S. claims data and adjusted for inflation to January 2017 using the Consumer Price Index. In terms of discounting, the quality and costs were discounted at an annual rate of 3%. This was conducted appropriately and was consistent with the second U.S. panel on cost effectiveness in health and medicine recommendation. Key inputs and assumptions were explicitly stated in Table 2 of this analysis. Reputable and reliable resources were used to make assumptions, including 4-year trial data, U.S. claims data, AHA-CV disease burden report, time trade-off study, the National Health and Nutrition Examination Survey, Novartis, and cholesterol treatment trialist collaboration. Because reliable resources were used, assumptions made can be considered sound and reasonable. Sensitivity analysis were conducted to assess the robustness of the assumptions made. Deterministic and probabilistic sensitivity analysis were used. Sensitivity and scenario analysis demonstrated incremental cost-effectiveness ratios ranging from $100,193 to $488,642 per QALY. Many variables were tested in these analyses. For example, a sensitivity analysis was performed using the Fourier patient population characteristics and cardiovascular event rate analysis.
Limitations were addressed by the authors, beginning with the discussion about external validity. One limitation here was the assumption that the adherence in the general public will reflect the adherence seen in this trial. Randomized clinical trials are known to model perfect scenarios and conditions which may not reflect the real world. Therefore, if it is found that adherence in the general public is not similar to the adherence in this trial, the cost-effectiveness analysis may be off. The limited time span of the trial is another limitation found, in the fact that the trial only lasted 26 months, but there's the assumption made that the benefits seen in these 26 months would continue on beyond the trial. If that assumption is found to be false, the integrity of the cost-effectiveness analysis may be compromised. Additionally, there's always the potential that unexpected adverse reactions may materialize several years after the trial has ended. The third limitation is that although the direct cost on the U.S. healthcare system is noted, the indirect cost that will be borne by the public has not been appropriately added into the analyses. Lastly, generalizability is a limitation discussed by the authors. It will be further discussed, but the authors noted that they conceded to the point that the only results of the study are only applicable to U.S. patients with established ASCVD risk, and not to multiple other patient groups. As mentioned in the previous slide, the authors noted that a lack of generalizability is one of the limitations to the study. All of the evidence noted by the authors was entirely focused upon patients with an established ASCVD risk and patients within the United States. However, if a different patient population was examined, such as an international patient population with a different willingness to pay per quality of adjusted life years, then the analysis might yield a different result. Extrapolations that were not made included primary prevention patients, patients at a low cardiovascular risk, and patients outside of the United States. Therefore, the extrapolations made by the author were appropriate because they were simply not made. An unbiased summary of the results were presented. The authors were very clear in noting their limitations and the lack of generalizability found in the research, but the conclusions of this study were simply based upon the ICERs that were calculated for these patients and for Evolocumab. The author's conclusion was that the current cost of Evolocumab, $14,523, as an addition to existing therapy for the management of ASCVD, exceeds the cost-effectiveness threshold. With an event rate of 6.4 per 100 patient years, the optimal cost should in fact be, in the author's opinion, $9,669. With an event rate of 4.2 per 100 patient years, the cost should be, in the author's opinion, $6,780. These calculations, as mentioned, were based off of ICERs, and not based off of author, physician, or patient opinions. Therefore, they were unbiased. Here's a list of the references used for this presentation. Thank you very much for listening.